The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/JTP860. Downloadable slides and practice aids are also available.
Hello, and welcome to our virtual webcast, Transforming Modern Care in AML, Clinical Solutions with Novel Agents for Diverse Patient Populations. During this event, we'll explore how recent evidence has changed our approach to managing a variety of AML patients and disease subtypes. I am Dr. Harry Erba, and I am pleased to welcome my colleagues Naval Daver, Courtney DiNardo, and Gail Robos. So let's get started with today's agenda. We are going to discuss three broad topics: new developments in patients fit for intensive chemotherapy, options for older patients unfit for intensive therapy, and targeting mutation-defined AML. Until very recently, this slide shows the traditional approach to AML therapy. For patients who are deemed to be fit for intensive chemotherapy by their physician, they were given induction chemotherapy with 3 days of an anthracycline and 7 days of cytarabine for approximately the past 40 years. Patients who achieved a complete remission then would receive post-remission therapy depending on cytogenetic risk groups. Favorable risk patients, those with core binding factor leukemias, would undergo high-dose cytarabine consolidation and then be followed, whereas the other 25% of patients with unfavorable risk cytogenetics would be allocated to allogeneic stem cell transplantation if available and if they were eligible. Now, the group that gave us the most discussion were those with intermediate risk cytogenetics, and it's specifically in this group that the mutational profiles have been used to help distinguish patients with a more favorable outcome, such as nucleophosmin mutated or biallelic CEBP alpha mutation without FLT3, and those with poorer risk disease, such as TP53, ASXL1, RUNX1, and high allelic burden of FLT3. And there we would make a decision between chemotherapy versus allogeneic stem cell transplant. Now, if the patient wasn't fit for intensive chemotherapy due to age, comorbidity, social factors, we would recommend clinical trial, hypomethylating agents with azacitidine or decitabine, best supportive care, or hospice care. And this was a very difficult discussion. The response rates with hypomethylating agents in terms of complete remissions are only about 20% and may take months to actually be seen. And so many older patients actually decided on best supportive care or hospice care instead of any therapy because of the lack of activity of the hypomethylating agents as single agents. And in fact, only about 35 to 40% of Americans over the age of 65 received any form of therapy. But things are truly changing, and it's been quite remarkable in the last 2 to 3 years, the number of new drugs that are available for our patients with acute myeloid leukemia. Midostaurin led the way with the first new approval in many, many years for FLT3 mutant AML in combination with intensive chemotherapy, induction, and consolidation. More recently, the oral type 1 second generation FLT3 inhibitor gilteritinib was approved for relapsed refractory FLT3 mutant AML. About 20% of AML patients will have a mutation in either IDH1 or IDH2 that leads to a block of differentiation and accumulation of blasts. Ivosidenib and enasidenib are orally bioavailable specific inhibitors of the mutant forms of IDH1 and IDH2 respectively, and have been approved in relapsed refractory disease and ivosidenib in previously untreated older unfit patients. Gemtuzumab ozogamicin came back. This is an anti-CD33 antibody drug conjugate. It was approved, a very broad approval, in both treatment naive and relapsed refractory AML that is CD33 positive. Chemotherapy isn't gone. CPX-351, a novel formulation of daunorubin cytarabine in a liposome, was approved for patients with AML following myelodysplastic syndrome, CMML, treatment-related AML, and de novo AMLs with poor risk MDS-like karyotypes. And then finally, and in my own opinion, most exciting because it addresses the majority of the patients that we see with AML now, are the approvals for older unfit patients with hypomethylating agents or low-dose cytarabine in combination with venetoclax and low-dose cytarabine with glastagib. Today, we won't be discussing about the last approval, and that is for the anti-CD123 targeted therapy for blastic plasmacytoid dendritic cell neoplasm. So with that, let's get started and talk about the new directions and treatment choices in older patients fit for intensive therapy. And I'm going to present to my colleagues in this tumor board one of my own patients, William, a 74-year-old man who actually had an absolute monocytosis for 2 years and mild thrombocytopenia for 6 years, had been followed with a presumptive diagnosis of ITP, but a bone marrow biopsy had not been done. He then develops constitutional symptoms with a leukocytosis and atypical monocytes in the peripheral blood. Bone marrow biopsy shows acute myeloid leukemia with severe fibrosis, and a next-gen sequencing panel detects 4 different mutations: ASXL1, SRSF2, TET2, and CBL. And so I'm going to turn to my colleague, Dr. Naval Daver, to discuss the treatment options for William. Naval?
Thank you, Harry. And these are very real-life cases that we're seeing. So this is a patient, 74-year-old, with a history of secondary AML, presenting with elevated white count, has background fibrosis, presence of the mutations that you see. So for this patient, I'm going to go through some of the data. The options are traditional induction chemotherapy with anthracycline and cytarabine, use of the novel liposomal formulation, which is CPX351, or lower intensity therapy combination of hypomethylating agent and venetoclax, or of course the other option is transplant, which usually we do after achieving a remission. So here's some of the brief data for the CPX351 versus the 3+7. This was a randomized phase 3 study that was performed specifically in a high-risk group of patients, which included patients with therapy-related AML, meaning AML with a prior cancer or rheumatological condition, received chemoradiation for that, or secondary AML, MDS, or MDS-MPN progressing to acute myeloid leukemia, or patients who had AML-MRC, which is AML with MDS-related changes, which is a WHO criteria. So this group is a very specific high-risk group with dismal outcomes, and these patients were randomized, about 300 patients were randomized 1:1 to receive the traditional therapy that was the standard of care for those patients at that time, which was 3+7 versus CPX351. And the primary endpoint of this phase 3 study was overall survival, which was met, as you can see in the survival curve here, with a median overall survival of 9.56 versus 5.95. Also important co-primary or secondary endpoints in these studies were the overall CR/CRi and CR rates, and it was also seen that the CR/CRi rate was significantly improved with the CPX351 versus 3+7 at 48% versus 33%. Very important, I think, from the study was the overall survival was improved, but in the end of the day, there is much more room for improvement. And so if we were able to take these patients through their entire course of therapy as we would like to for such patients, which is induction, followed by stem cell transplant, here you see the curve showing the landmark post-transplant, where you do see quite a significant plateau and improvement in survival post-transplant with the CPX351 versus 3+7. And unfortunately, we did not have minimal residual disease either by NGS or by flow to know why we're seeing these significantly improved post-transplant outcomes, but the hypothesis is that either we were seeing deeper remissions pre-transplant, which is usually associated with better transplant, post-transplant outcomes, or maybe the tolerability of the agent was better, allowing patients to be in a better physical condition at the time of transplant, or maybe it was a contribution from both. But we have to hypothesize because we do not have MRD. But nonetheless, if you give these patients CPX351, get them to transplant in this high-risk group, you do have some meaningful chance of post-transplant survival. This was some of the data that was shown at ASCO meeting in 2020, a few weeks ago. And here, this was long-term follow-up, 3-year and 5-year follow-up of patients in this phase 3 study, CPX351 versus 3+7. And it was encouraging to see even at the 3 and 5 year follow-up among all patients, there was a maintained improvement in overall survival, maintained separation of the curve. And even more importantly, I think from a practical or clinical use of these agents, you see that in patients who were given CPX351 and made it to transplant, important to note that actually more patients made it to transplant, 35% versus 25%, probably because of the higher response rates. And when the patient made it to transplant, post-transplant, you actually see quite an encouraging survival with the median actually not reached, and at 3 and 5 years, 56 and 52%. So remember, this is a high-risk group, and to see that duration of response in the 3+7 is quite encouraging. So confirming the initial findings that were seen when the paper was initially published in JCO. Important to note that this is a form of chemotherapy. So, what I tell a lot of community doctors or others who will ask us is, if you're admitting patients for your standard induction, like 3+7, I would say admit them for CPX351. If you're comfortable doing early discharge and monitoring with 3+7, then you could do that with CPX351. It's a more effective form of anthracycline cytarabine, in my opinion, but I don't necessarily think it falls into a lower intensity. Now, it is better tolerated, especially from the GI toxicity perspective in our experience, and that is probably one of the reasons you see this lower early mortality. The day 60 mortality is 14% versus 21%. So it's still above 10%, and it is still a moderate to high intensity therapy, but lower than 3+7. And the side effect profile that you see is quite similar to what is encountered with 3+7, with infections being the most common. So in most scenarios, patients are being admitted. There are some hospitals due to DRG or other reasons starting inpatient and considering subsequent outpatient. I think everybody's coming up with their own system. In our experience, we have been admitting these patients and monitoring them inpatient using similar transfusion parameters as we would do with a 3+7. Also important to note that there's a slightly prolonged count recovery with the CPX versus the 3+7, about 6 to 7 day prolonged recovery for neutrophils and platelets. So that should be factored when you're giving this agent and considering when to start the next cycle of treatment. And with that, I will turn it back to Harry. Or did you want me to?
No, thank you, Naval. That was great. So, one of the things that occupies our time in clinic is having very difficult and deep discussions with patients who are well, who are facing now a life-threatening illness in terms of their goals of care. This patient was quite clear with me. He was otherwise very healthy. He didn't want another 1 or 2 years. He wanted to live as old as his mother back in Serbia, who was approaching 95 years old. And so I felt that allogeneic transplant was the best option for him. And so given the data that Naval just went over, chose to treat him with CPX351. He lived close to our hospital at Duke University. He had a caregiver. He was quite reliable. And he didn't have leukocytosis or any febrile neutropenia at baseline, so I felt he was a good candidate for outpatient therapy. Treated him. He did have a brief admission for a couple of days for culture-negative febrile neutropenia, but ultimately achieved a CRP with therapy. He went on to receive 1 cycle of consolidation, was in a complete remission. In fact, our NGS panel that has a threshold of detection of about 2% blasts, about 1% allelic frequency, was negative now. And so he underwent allogeneic stem cell transplant with a Flu-Mel preparative regimen and a haploidentical transplant. And now I could say, this is an older slide, but more recently, 4 months later, in June of 2020, he is still doing well. Now, the interesting thing about him is the choice of this therapy, because he didn't really have AML with myelodysplasia-related changes as defined. There was no documented history of MDS, no dysplasia, and the karyotype was normal. However, he did have this provocative history that truly suggested he had an underlying myelodysplastic syndrome or CMML. And here we see also the mutational profile with a chromatin modifier mutation, ASXL1, and a spliceosome mutation, SRSF2, which Coleman-Lindsley has published is associated with a higher response rate and survival with CPX351 than with 7 and 3. Of course, I didn't know that data at the time of choosing that. But I would turn to my colleague Gail and say, how about other subsets? We're often challenged, who's the perfect patient for CPX 351? Are there any other hints from the mutational profile?
Well, I think here, when you're looking at somebody with an abnormal CBC for years, and a lot of these patients do come in with kind of what the theory was a few years ago. Well, maybe it's ITP, maybe it was this, maybe I had a cold, maybe I had a virus. But it's kind of, quacking and looking like a duck and feeling like a duck, and it's probably a duck. So this patient probably did have an abnormal marrow. I think dysplasia is very, very difficult to characterize and sometimes is candidly misleading. So I think when you're looking at a patient like this, the aggregate of data plus the generally favorable extramedullary toxicity profile of CPX, you've got a guy in good shape with a really suggestive combination of labs and mutational profile. It's kind of, you would really be having to have a reason not to give CPX 351. And your reason not to is what we're going to be talking about over the next few slides, which is that, wow, we actually have some choices in AML, and we probably could debate whether this patient, although perfectly excellent for CPX 351, why not use, for example, a venetoclax HMA-based regimen for a patient like this, even though the label for that might be for more frail patients. I think it begs the question going forward of why couldn't this patient get that type of a regimen and even potentially proceed to a transplant. But I think we'll save the answer for that perhaps to a few slides from now when we dig into those regimens. Harry, I'll leave that up to you.
Okay. Well, I appreciate that. And, let's move on. I think you've set that up very well, because really the challenge now compared to just 3 years ago is we do have so many options for our patients. So let's move on now to the older patient who's fit for intensive chemotherapy. And something that we've been looking at for many, many years, we know that the relapse rates are so high in our older patients who get intensive chemotherapy. But despite, again, years of maintenance, clinical trials evaluating maintenance, we've never seen a benefit of any maintenance approach. And that may be changing. And I'm going to ask Gail to discuss my next patient, who's Bertram, a fit 65-year-old man with pancytopenia, normal karyotype AML without a FLT3 mutation. He has the mutational profile shown there, again with chromatin modifier mutation. He has EZH2, a cohesin mutation, and STAG2, again, 2 mutations associated with a secondary type of AML. After initial consultation, however, apparently a de novo AML, not AML with myelodysplasia-related changes, he received 7 and 3, and he does respond and receives 1 cycle of consolidation. However, he is still very reluctant to undergo stem cell transplantation. I will tell the group that at the end of that, his next-gen sequencing panel still showed an EZH2 mutation. So my question then for Gail is, what would you do? Would the next-gen sequencing panel have affected the initial therapy, as we just talked about? But more importantly, is maintenance going to be an option for this patient? Gail?
Well, I think that, so maintenance has been, as you've said, it's not been a home run in AML, but there have been hints of why maintenance would be a potentially important addition to what we do for leukemia patients. So obviously we all know that in ALL, maintenance transformed everything. So maintenance therapy took children who were dying after initial treatment for ALL, and maintenance extended overall survival significantly. Maintenance is still standard of care for adults with ALL. So what's the problem with AML? Well, we've had hints over the years. Event-free survival maybe was improved in a couple of scenarios. We've had hints recently that HMAs, hypomethylating agents in the maintenance setting, could be helpful. But we haven't had an overall survival benefit, and we haven't really had anything that was well tolerated enough that people wanted to deal with it in remission. And candidly, the problem in remission is that you finally have some decent quality of life, you don't want to get hammered with multiple cycles of chemotherapy unless you really are sure that it's going to be helpful for overall survival. So we were pretty thrilled, actually, with the phase 3 data for Quasar, which have been presented at the past ASH meeting, and then with quite a lot of additional data being presented at ASCO and EHA. So this is looking at CC486, which is an oral hypomethylating agent. It's an oral version of azacitidine, not the same exact thing. So before anybody thinks of it as a one-to-one substitution, this is still a different drug. And this was looked at as maintenance therapy in AML. This trial took a long time to accrue, but it's worth it. And it kind of touches all the bells and whistles of being phase 3, international, randomized, placebo-controlled. And if you look at how it was set up, basically these are patients in remission. So we have a large study of 460 patients, people over 55 years who are in remission, CR or CRI, after getting intensive induction chemotherapy plus or minus consolidation. They could have actually a performance status ranging from 0 to 3, and these were patients who were deemed ineligible for stem cell transplant. Lots of possible reasons why they were ineligible, but they were not going on to transplant, and they were eligible for this trial, which involved maintenance therapy, ongoing cycles of CC486 for 14-day cycles versus placebo. And if the patients were responding, they could hang out on the drug. If they had any evidence of an early recurrence of disease with 5 to 15% blast, they were able to actually escalate to 21-day cycles of CC486. And if there was a relapse, they would stop therapy. And what really has turned out well here is that we were able to get a tremendous amount of follow-up data and also very long follow-up overall. So the money shot here is that there was a statistically and clinically significant overall survival benefit. So that's the first. That's the first time a maintenance therapy has shown overall survival benefit in AML. And actually, when you looked at all of the subgroups, older age, bad cytogenetics, all of the things that make therapies not usually work in AML were still favoring the CC486 subgroup. Additional data that were presented at these last couple of meetings showed that, for example, health-related quality of life, which was actually pretty good for the group when they entered the trial, which is understandable for a group of patients in remission, it was maintained. So patients were able to get multiple cycles, 7, 8, 9, 10, 11 ongoing cycles of therapy without any reduction in their baseline quality of life, which I think is very significant. In addition to that, it's been shown that the older patients, the ones 75 and older, were actually able to complete this therapy and did well and had a survival benefit. And that is certainly a group that while you can do an allo transplant, most people are not thrilled about doing allo transplants in 75 and older. And even for 70 to 75, as you discussed in the last patient, it's very controversial. And I think that these additional data, so can we salvage some of the patients who have a rising blast count? Can we convert MRD negativity? Can we consider this therapy as something that could be used instead of a transplant? These are all huge questions that we want answers to, but I do think that this is going to represent a new standard of care for AML, and maintenance is now on the map.
Well, and adding to that, there was also an update about this subgroup of patients who, while on this prolonged maintenance that continued until disease progression or intolerance, that in the subgroup of patients with the 5 to 15% blast, in other words, they're starting to relapse, when they went up to a 21-day cycle, about a quarter of those patients actually did achieve a remission and survival was better in them. And this patient that I was just telling you about, where you know that they have a mutation still present that has been associated with recurrence of the disease, that in those MRD positive patients, there was still a benefit of oral azacitidine CC486. So I do think it is going to change our standard of care.
Yeah, I think it's, we really are hoping for a treasure chest of more data coming out. I mean, I think we all have a lot of questions. What do we know, if anything, about baseline mutational status? There are a lot of things that we're still working through. The trial actually took a really long time, and many of the technologies with respect to next generation sequencing weren't applied actually at all when we first started, and then to varying degrees through the study. Certainly the MRD technology with respect to PCR-based flow cytometry, all of these things have evolved enormously in the last decade. And, I think it's going to be imperfect, but a lot of data will come out of this study. And I think for your patient, actually, your patient really begs the question, because he really wanted to go on to stem cell transplant and was in great shape for it and has done well. But had the patient not wanted to, or perhaps didn't have a donor that you were happy with, I think that these data really provide another alternative other than just watching and waiting for the disease to inevitably relapse pretty quickly, which is the situation that we've often been in until recently.
Yeah, and I think it's important to point out, although that the median survivals were improved and survival at 24 months is higher, these curves do come together at about 4 years. And so for the patient who is eligible for allogeneic stem cell transplanted, it should definitely be considered. But I could tell you, I refer a lot of my older patients for stem cell transplant, and there are many, many reasons why they are not choosing that approach. And so I look forward to having something more to offer these patients. So any other comments from our group?
I will say, if I may, according to Nardo here, that I think one of the next steps for this, talking about transplant or not, and using oral azacitidine in patients who receive intensive chemotherapy, go into remission, and who do not decide to proceed to a transplant. I think the natural extension for this may be evaluating whether there's a role for oral azacitidine in the post-transplant maintenance setting, right? So that is, of course, a major outstanding question, but certainly, there are some very nice preclinical as well as early clinical trials suggesting that lower doses of azacitidine can induce, T regulatory cell expansion and can enhance graft versus leukemia effects. And so I really am looking forward to seeing whether there's a role, in the post-transplant setting as well.
Completely agreed. We're all looking forward to getting this drug in our hands so that we can see if there are other things that might benefit our patients. So let's look at a couple of questions from our audience. And one of them is the outpatient use of CPX-351, which I think we touched on, but the interesting corollary of that is, do you think this whole COVID-19 pandemic has affected how we treat these patients? Naval, I haven't heard from you recently. What do you think?
Sure. Yeah. So, our approach at Anderson for CPX-351 has been to do it inpatient. We consider this as a form of induction, and we usually have been admitting these patients. I think for the COVID-19 scenario, it actually has to some extent changed our practice in those kind of gray area patients. So the 65 to 75-year-old patients, whom it may be difficult for them to travel, or we're worried about them traveling to the hospital. Now, mind you, in Houston, we did not see the level of surge that has been seen in New York and other places, so there was not a lockdown. But let's say there was a concern. I think drugs like HMA venetoclax or oral agents, FLT3 inhibitors, or novel combinations in the relapse of venetoclax, FLT3, venetoclax, IDH have been preferred because they can offer less travel, especially from out of state, to come into Houston or wherever the large center may be. And we've had a lot of emails and requests for information on how we're giving some of these novel combinations. I don't think it has, at least in my opinion, pushed the use of induction or outpatient induction. So if we're going to do something for COVID adjustment, I think we're going more towards a true low intensity, whether it's oral, or HMA with oral therapy use. And I think that's where we have to be careful. I think CPX-351 is more effective. It is better in ways of GI toxicity, but it is still myelosuppressive, and count recovery is still 35 to 38 days. Febrile neutropenia rates are still similar. So I would not necessarily shift from 3+7 if I was doing it inpatient to going to CPX and just doing it outpatient in general.
Yeah, I agree with you, Naval. And in fact, I think it's interesting. We're doing a lot of things in response to this COVID pandemic that we think make sense, but you got to wonder, do they really? For example, At Duke, when we admit a patient, we screen them for COVID. We screen all of our staff for symptoms of infection, and then they're not allowed to have visitors. Is that potentially a safer way of giving any induction, CPX 351 or 7 and 3, compared to HMA venetoclax, where they're coming back and forth, 2-3 times a week for count checks and transfusions for many weeks and being multiply exposed? And I don't know the answer to this, so we'll just do the best we can. Okay, I will move on for the sake of time. We already dealt with the question of maintenance after allo transplant, so let's move on to options for older patients with AML who are unfit for chemotherapy, intensive therapy. So this is George, a 72-year-old man, again with normal karyotype AML without FLT3 mutation, who presents with pancytopenia, has a few comorbidities. He has a performance status of 2. The comorbidities don't really preclude us from thinking about intensive therapy, but at the time of his initial therapy, he has a performance status of 2. Is that the disease? Is that his other health issues? Well, we'll have to see. So he receives azacitidine venetoclax, achieves a CRH after 2 cycles. Interestingly, after the first cycle, your next-gen panel comes back with nucleophosmin mutation, TET2, and DNA methyltransferase 3A. And so one of the questions that will face us is, do we continue a maintenance approach in a patient like this? Is there data for allogeneic stem cell transplant? And to lead off this discussion, I'm going to turn to Courtney DiNardo, who has really been on the forefront of the development of the HMA venetoclax combinations. Courtney?
Perfect. Thank you. So we'll just kind of recap this patient, who is a perfect example, I think, of where the field has gone in terms of improved options for our older patients who are potentially unfit for intensive chemotherapy. So a 72-year-old gentleman with underlying comorbidities, hypertension, diabetes, and as Harriet said at the beginning, many of these patients, the majority really in the United States up until recently, were not even offered any sort of therapy at all. And so this patient receives the combination of azacitidine and venetoclax and goes on to have a rapid remission, a CRH, with CRH meaning that the neutrophil count has improved above 500 and the platelet count has improved above 50,000. So while not a true formal CR, many, including myself, in the academic world think of CRH as a particularly clinically meaningful endpoint, suggesting patients are, out of the hospital, not at risk of frequent infections and not needing transfusions. And so, we have many of these patients now doing quite well in early responses on HMA venetoclax. And now the question is, shall we consider transplantation? Our idea has always been, a transplant is something that we do for younger, fit patients who are in a remission with intensive chemotherapy that have high-risk disease and a high risk of relapse. And so this really, for the first time, we have patients doing well enough in this other bin of our older patients where should we be considering transplant. As far as how well our patients do with these combinations without transplant. These therapies have not been around for so long, so we don't have a lot of really long-term follow-up data. But the more we're seeing these patients, the more we're realizing that very few of our patients are cured with this combination alone, if any. And so transplantation is definitely something to consider. And so this is a key study that was presented by Keith Prats on behalf of the investigators of that original phase 1 study of AZA, or decitabine or low-dose cytarabine with venetoclax. So they pulled all the 300 plus patients that were treated on the initial phase 1 studies and looked at those patients who went on to transplant. And so, of course, transplant wasn't part of these original studies. And so this was kind of a post hoc analysis where as much information as could be gleaned was provided. 31 patients out of 300 and so went to transplant, so about 10% of patients on those original studies were able to or decided to proceed to transplant. The majority of patients were in a remission at the time of transplant. We don't have MRD status, so we don't really know how MRD impacted patients who went to transplant. But what I think is suggestive in this slide is that the majority of patients who were able to proceed to transplant did well. The 1-year overall survival rate in people that went to transplant was 84%. And actually the 2-year follow-up. Almost half of the patients that were on the study, again, remembering they're unfit for intensive chemotherapy in the first place, they received therapy. Some of their performance status improves in theory, right? Their leukemia is in a remission now. They're doing better outpatient. They become transplant eligible. They go to transplant, and almost half of them now are alive 2 years later. And I think that's a really kind of compelling statement suggesting that transplant should be considered in our patients such as this.
Courtney, before you go on to the Viale A and C trials, there's something really important about this observation. And as you said, this is a well-selected group of patients. Like my patient, the performance status improved and would be able to go on to transplant. But what was impressive here is that out of the 31 patients who went on to transplant, all but 3 of them went on to transplant in a morphologic leukemia-free state or a response with the initial HMA or LODAC and VEN. It was only 3 who got something else. And so this really does reflect the activity of this regimen to get people to a transplant where the outcomes, where you would imagine most of these patients got reduced intensity transplants, was quite good.
So I'm going to move on and just provide a little bit of, I think, 3 slides of information about the Viale study. So just to kind of orient everyone. So we had the original phase 1-2 trials of low-dose cytarabine with venetoclax and azacitidine or decitabine with venetoclax. And both of these studies showed really compelling response rates and overall survival, and those went then into the confirmatory phase 3 clinical trials. And the Viale C is the low-dose cytarabine with or without venetoclax. It was placebo-controlled, international, all the bells and whistles, as Gail put it earlier, on these large phase 3 confirmatory studies. And this study was a little bit of a disappointment, I think, is the easiest way to say it, where you saw improvements in remission rates. From the CR/CRi rate went from 13% up to about 50%. You saw improvements in transfusion independence, event-free survival, and somewhat overall survival, but it failed to meet that primary overall survival endpoint. So that's what's represented here. There was an improvement in overall survival in a additional kind of post hoc 6-month follow-up analysis showing the difference was 4 months with low-dose cytarabine, which is right where we expect low-dose cytarabine to be, and with a combination essentially doubling median overall survival to 8.4 months. And so while this did not reach its primary endpoint, I think it was, there's clear still clinical significance for this study.
Now, Courtney, that study did allow patients to have a prior HMA for MDS. Could that have affected the outcome here?
And that's a good point. So about 20% of the patients who were enrolled were HMA failure is the term we use. So it had an antecedent hematologic disorder that had received either azacitidine or decitabine in the past. In that population, the remission rate was incredibly poor. I think it was less than 10%. And so, certainly that was considered within the primary endpoint. Stratification was based on prior HMA therapy, but I think that is the one key difference between the Viale C and the Viale A, other than the backbone of low-dose cytarabine versus the hypomethylating agent. But the fact that in this low-dose cytarabine study, you could have failed a prior HMA therapy, which we know from experience, those patients do incredibly poorly, unfortunately, no matter what therapy we offer. I think one of the key questions when we're talking about venetoclax combinations is the safety of that. We're taking a older, kind of risky patient population that has, trouble sometimes with standard therapy alone. And when we're adding venetoclax, is that really increasing the safety and toxicity of these therapies? And I think, one of the important things that was shown here is that in terms of discontinuation, the rates were very similar. In terms of serious adverse events like pneumonia, sepsis, really quite similar between arms. The one main difference that you'll see with venetoclax combinations is an increase in cytopenia. So there are more hematologic adverse events, in particular neutropenia, that is known that was seen with the early phase 1 combinations, and that's again demonstrated here. And I think, that's one of the the most important, I think, management things when you're giving venetoclax combinations is to make sure you're monitoring your patient well, especially at the beginning. These responses happen quickly. They're not 4 cycles later, 6 cycles later, like we see a lot of times with our with low-dose cytarabine or azacitidine alone. They happen really quickly. So the cytopenias that we're seeing in our patients at the end of that first cycle are not necessarily underlying leukemia, because the leukemia very well might be gone at that point. And so doing that endocycle marrow, trying to identify the leukemia status of your patient. If there is no evidence of leukemia, waiting a week or 2 for counts to recover, considering growth factors, things like that are really important mitigation techniques to help your patient and you manage your patient with cytopenias.
Waiting a week or 2, holding the venetoclax during that time.
Yes.
Yes. Okay.
Yes. Thank you for making me clarify that. Yes. When I say kind of waiting a week or 2, holding the venetoclax prior to starting the next cycle, where you're starting both of the 2 agents up again together.
Yeah, and I just want to jump in there because it's so super important that somehow doctors sometimes think that if you have to hold or if you have to wait, that's a failure, or it means something isn't working. We've got to get rid of that, because that is absolutely just part of these venetoclax-based regimens. There are dose reductions, there are changes, there are holds and wait, but that doesn't actually mean that you should move away from the therapy. And somehow in other aspects of oncology, that's well, maybe this isn't the right regimen, maybe it's too strong. Here, it's just part of the day. And I think that has to be very much emphasized in the management plan, that it should be absolutely expected, that there should be holds, and that it shouldn't be considered a deterrent or making you think that the regimen is not on the right track. It's kind of the optics of it, and we have to get rid of a bad stain that comes along with treatment delays.
I think, we've for so long have had, I'll pivot to azacitidine. We haven't had great curative options, right? So you want to try maximize that azacitidine as best you can, and you want to stay on track. You want to give 28-day cycles. And you're exactly right. That's no longer necessary. If you wait a week or 2 to have counts recover and optimize the care of your patient, patients do so much better. And I believe it was like 40% of patients, if I'm remembering the number right, 40% of patients require a delay between, the first cycle and the second cycle to allow those counts to fully recover. And those are the patients that are doing well. So you're exactly right. Don't think of it as a failure. Think of it as, we'll go back to Davar's example of lung cancer, a Tarceva rash, right? You see that rash and you're excited because your patients are doing well. It doesn't mean that it's a side effect that means your patient's not. So spending a minute or 2 on Viale A. So Viale A is the confirmatory phase 3 trial of azacitidine with venetoclax versus azacitidine with placebo. Another large international placebo-controlled trial. Over 430 patients were enrolled, and this one hit the primary objective. So that, the most important thing here is to see that improvement in overall survival, which was associated with a hazard ratio of 0.66, so like a 34% reduction in the risk of death in patients receiving this combination. The adverse events are really the same as what we talked about, but actually a little bit more magnified with azacitidine. You see more neutropenia and more febrile neutropenia with the azacitidine combination. So all those things we were just talking about are important here as well. The one thing that people, I think, associate the most with venetoclax is the risk of tumor lysis, because people are used to giving venetoclax in lymphoid diseases, CLL lymphomas, where there's big, bulky tumors, and TLS is a very kind of life-threatening and serious concern. And I don't want to minimize it, but I will say that, using the daily dose ramp up, so over 3 or 4 days, you're increasing the venetoclax while you're giving the azacitidine. Your patients are being monitored. You're giving a uric acid reducing agent. There was, just a small number, 2 or 3 patients that had any even laboratory evidence of tumor lysis. Drug didn't need to be held. There was no major interventions required. And so while it is something to be aware of, and you need to be, monitoring your patient at the beginning of therapy, tumor lysis was really not a significant adverse event in either of the AML studies.
I think I will have to leave the discussion, even though there's a lot of very important points there. I apologize. But I do want to get on with some of the more targeted things. We talked about tumor lysis syndrome and management of neutropenia from our audience. So let's talk about targeting FLT3 and IDH mutation. So very quickly, Carol is a fit 65-year-old woman who presents with anemia symptoms and night sweats, has a high white count due to a leukocytosis, has a FLT3 ITD positive AML with a normal karyotype, nucleophosmin is present. And based on the results of the RATIFY trial, she receives 7 and 3 with midostaurin on days 8 through 21, followed by intermediate dose Ara-C with midostaurin. Now, the RATIFY trial did not have patients over the age of 60, but the German experience, the AML 16-10 study, did look at older patients, and compared to historical controls, they seemed to do better. They tended to have a little bit more anemia, a little bit more GI toxicity in that clinical experience. But the labeled indication is quite broad. The FDA approval is for all ages of adults with a newly diagnosed FLT3 ITD positive AML. So I want to turn this now to Naval and talk a little bit about any toxicities that you think we need to manage. Maintenance midostaurin, it was in the RATIFY trial. Do you use it? Is there data to support it? And the value of allotransplant in first remission. Oops.
Yeah, and in the interest of time, I'll kind of go briefly through some of these. Midostaurin in general, well tolerated. The toxicity we've seen is rash. It's seen in about 10 to 15%. Usually is a minor issue. Topical steroids will take care of it. We do not see significant prolongation of myelosuppression or other major toxicity. So in general, I would say quite well tolerated agent. Maintenance with FLT3 inhibitors in general, we do use them. I think this has been a point of great debate, and even the approvals in Europe and US are different, whereas in the US it's approved only in the induction consolidation. In the Europe it has more of the label that is matching the New England paper, where it can include maintenance. In general, I think given that maintenance was a part of the treatment in the intent to treat analysis that was done in the phase 3 RATIFY, and also given data from many other sets showing maintenance post-transplant, maintenance in general with other FLT3 inhibitors for sorafenib, we are doing maintenance in general, whether it's post-induction consolidation or whether it's post-transplant. And in general, I would say for all FLT3 mutated, as a broad 10,000 views approach, we are trying to take them to allotransplant. There is data emerging in particular subsets such as NPM1 mutated FLT3 allelic ratio low, below 0.5, where there may be survival benefit with or without transplant. That data is not yet clearly analyzed and published. So for general, we are sending FLT3 mutated transplant, and we are doing post-transplant maintenance with a FLT3 inhibitor.
Thanks. So on maintenance, this patient develops recurrent thrombocytopenia and a relative monocytosis and surveillance blood counts, and her marrow shows recurrent AML. Naval, do we need to repeat that mutational analysis? And if it does show the FLT3 mutation, what would you recommend?
Yeah, absolutely. So I'll discuss the next few slides, which kind of cover the therapy aspect. But for sure, I would repeat the mutation analysis. There's 2 or 3 retrospective data sets that have been published showing that the FLT3 is highly dynamic, can both be acquired and lost. One of the studies we had published many years ago showed that about 10% of patients may acquire a new FLT3 that was not present at baseline, at diagnosis. And then there's recent data from the RATIFY subset analysis showing up to 30-40% of patients could lose FLT3 at the time of relapse. So I think it's very important to check, because you don't want to give a FLT3 inhibitor single agent like gilteritinib if there's no detectable FLT3, and vice versa. You don't want to miss an opportunity to give a targeted therapy if a new FLT3 has either been acquired or has expanded. Now for treatment, I think in the relapse FLT3 setting, the most important trial so far is the Admiral study. This was a randomized phase 3 multinational study randomizing relapsed FLT3 mutated either ITD or and or D835 mutated patients to receive single-agent oral targeted second-generation FLT3 inhibitor gilteritinib versus investigator choice therapy, which could include high-dose treatments like MEC FLAG-IDA and low-dose treatments like low-dose Ara-C, HMA. Majority, 80% of the patients were pre-selected to high dose. So really, I think most of the people, it was gilteritinib versus high dose. And what you see is here, gilteritinib actually improved as a single-agent oral treatment, both response rates, true CR rate, as well as CRC, which is kind of traditionally how most of the FLT3 data has been analyzed and presented, was double with the gilteritinib as compared to the salvage chemotherapy of FLAG-IDA, MEC, or HMA. And importantly, the co-primary endpoint of survival was met, showing 9.3 versus 5.6. I think this is a very, very important study. I mean, the point here is that oral targeted agent is not only showing similar activity to a 3-drug IV chemo, which I think in most solid tumor world would be a huge blockbuster hit. You're actually showing superiority. So this was not a equivalence, it was superiority with one oral drug versus high intensity inpatient IV chemo. So really showing the power of targeted therapy. But at the end of the day, 2 years, the survival is coming down for most patients. So I think it's a good starting point, but now combinations with HMA, with venetoclax, with HMA venetoclax, with chemo will hopefully further improve the tail of that survival curve. And this was a study that actually very interestingly allowed patients to go to transplant while on study and resume gilteritinib post-transplant while remaining on study. That occurred in a small subset and showed that if you continued gilteritinib post-transplant, you could further potentially improve the survival. And more data coming out from sorafenib, as well as a large phase 3 randomized study of post-transplant gilteritinib will hopefully be presented, seems to suggest that maintenance post-transplant is going to improve outcomes. So this is kind of total therapy that you need to consider for FLT3, where you give induction, FLT3 inhibitor, transplant, post-transplant maintenance, and then you can really improve the survival for those patients.
Thanks, Naval. Those patients are very highly selected who were able to go back on gilteritinib, weren't sick with fungal infections, but so it's not randomized trial data, and that is pending from the BMT CTN, that study of gilteritinib versus placebo. And so that study should continue to accrue so we can truly answer the question of the value of gilteritinib. And of course, there was quizartinib in the QuANTUM-R study that was similarly designed, showed an improvement in responses, improvement in survival, improvements in outcomes post-transplant, and has been approved in Japan. Let's move on to yeah, go ahead, Gail, please.
I think it's just worth it to just one quick point. So, being able to do things in AML is just fantastic. Having options is fantastic. But one of the things that is kind of interesting as we look at all of the maintenance settings and what we do post-transplant and what we do post-chemotherapy is sort of the realization that this is not a one-and-done disease. And our mainstay of curative therapy of allogeneic stem cell transplant, which still does cure patients with AML, but the question is really, does the therapy ever end here? And I think that with IDH inhibitors, with FLT3 inhibitors, with oral hypomethylating agents like CC486, as you have increasingly well-tolerated agents, and as the biology of the disease continues to show that there are leftovers even beyond our most intensive strategies, one does have to think about the question and what it's like for patients to ponder that, can I just be done? Or do I have to be on something forever with this disease? So I just thought I would throw that in there because it's really kind of a new way of thinking about AML. AML is hypertension. You're going to be on a drug forever. We haven't really thought about it that way.
I completely agree, Gail. And the exciting thing is my earlier conference call today actually was with the NCI and the NCTN on this Milo match, where we're designing clinical trials that use next-gen sequencing and MRD assessments post-allo transplant, post-curative therapies to intervene specifically for mutations that may still be present. So I think our entire management of AML may very soon be changing. But let's move on and talk about the 20% of patients with IDH mutation. I'm going to start with this one. And Gail, I'm going to give the case to you because it's a question that comes up because we now have two options that are for this patient. A 70-year-old woman with fatigue, night sweats, has a couple of comorbidities against a performance status of 2, pancytopenia, a marrow showing multilineage dysplasia, so you could think about CPX351, but she has a performance status of 2, so maybe not. In any case, her PCR shows an IDH R132 mutation, but negative for FLT3. Okay, so now, Gail, you published the first author on the ivosidenib single agent study, and there's HMA venetoclax where this group does well. How do you choose?
Yeah, well, I feel a little bit silly after 15 years of lamenting not having any choices. It's a little bit strange to lament having choices, so that doesn't work. But I think that, it's really hard. If you look at the IVO data, the way that the trial was set up to allow the opportunity to look at the drug in relapsed patients as well as in newly diagnosed, I think was absolutely fantastic. I mean, we have now mutationally driven therapies, but you know what? Venetoclax hits a target too. So it's not a mutation. BCL2 is a target. Do you have to hit, if you see a hammer and a nail, is that what it's like with FLT3? Is that what it's like with IDH? Venetoclax hits a lot of different things. Ivosidenib has a very strong CR/CRh level of 40+%. It is well tolerated. It is certainly less myelosuppressive as a single agent than the HMA plus venetoclax. But HMA-Ven is looking at response rates of nearly 70%. I mean, in the high 60s for patients with IDH mutations. Both of them can result, both IVO and the HMA-Ven can result in mutational clearance. And I think that currently it really has to be some individual patient circumstances that make the decision to help you. Is there a reason why they may not be able to tolerate the increased myelosuppression of the doublet? Is there a reason to try IVO first and then go to the doublet if it's not working? It's hard, and it's actually worse than hard because I'm going to toss the baton to Courtney in a minute, but what about ivosidenib plus azacitidine, which might be even better? What about that comparison versus HMA-Ven or azacitidine-Ven? And then even worse, what about a triplet? So since that's completely unanswerable, I'm going to give it to Courtney.
Yeah, and Courtney has to be careful because this is a myeloma question, doublets versus triplets. That's 5 or 10 years ago. And I'm a leukemia doctor. I could do 2 drugs. I'm not sure I could do 3 drugs, but tell us how to do it, Courtney.
We've got to say this. Don't do this at home, right? This is not supposed to be cocktail hour in AML land where we're just putting lots and lots of things together. And I think we have to have a reality check on availability, on whether or not the patient is going to be able to get these drugs. Where are they in the world and in the country, putting them all together. So I just want to make sure that this is not coming out as a recommendation to just mix and match at home, even though what Courtney's about to tell you is completely compelling.
So what I will say is we have an abundance of treatment options and all of them are good options, right? So we have ivosidenib alone that may not be, as compelling in terms of a complete remission rate. So in the frontline setting, you have about a 30 to 40% response rate, but the median survival is over a year. That's better than what we would expect potentially with azacitidine alone. So I think, So there's IVO alone, maybe in patients who had underlying MDS that have had a lot of prior therapy. It's not a wrong option in some patients. But I think the main crux of the question is, as Gail had said, AZA venetoclax or AZA ivosidenib. Both of those studies have been presented. Both of them show remission rates upwards of 70%. Both of them have very durable survival. IDH1 mutant patients do incredibly well with either of those options. And so you can't really go wrong, and you have to try to figure out, try to kind of outsmart it a little bit and figure out, are you really concerned about cytopenias for some reason that would steer you away from venetoclax? Or are you really concerned about differentiation syndrome, someone with underlying congestive heart failure, perhaps, that you think really shouldn't get the combination and the concern for differentiation syndrome?
Let's move on to talk about IDH2. But I'm going to start with this case, a 70-year-old woman with MDS and ASXL1 who actually got azacitidine with a hematologic response for the MDS. She's truly frail, I would say, has really significant comorbidities, and then develops progressive neutropenia and thrombocytopenia with 60% blast multilineage dysplasia, still not a chemotherapy candidate. I would add CPX351 to that as well. And so the options really come down in this patient who has a prior HMA to these combinations. Gail, how would you select between these?
Well, so again, you want to treat, you want to try to treat, because if you're not treating somebody, even if they're frail, you're saying that they're going to die and reasonably soon. So you're going to look at this patient and say, all right, I don't super want to give a lot more azacitidine. She's had a lot of it. This would be a potential spot for low-dose cytarabine and venetoclax, again, with careful monitoring. This is a patient with renal failure to start out with, so you're going to kind of look closely at that patient. You're also going to watch carefully for your cytopenias, coronary artery disease. You're not going to let her get terribly anemic, and you're going to watch that cycle duration. I also think that looking, though, do you switch HMAs? So I think that's a hard question. I think in general, we don't like to do that for MDS or AML patients who historically have been on one drug and not responding or losing a response. We haven't loved switching to another one. Here, decitabine has a little bit better data, the slim, but a little bit better perhaps in renal failure than azacitidine. So I do think it's an option, although there is a temptation to use low-dose RSC given the long HMA exposure. And I think, the question of Glasdegib and low-dose RSC, so the regimen, although Glasdegib has an interesting mechanism of action, the regimen overall has been overshadowed by the extremely high response rates seen with the venetoclax-based regimens that are definitely higher than with this combination. But we do have it as an option in case we feel that venetoclax just can't be given to this patient due to whatever is going on with her kidneys. I still think we're probably going to try option 1 or 2.
Well, and those seem to be the only options, but Courtney, you actually published some data about the appearance of IDH mutations at the time of progression and of MDS, and that's exactly what happened. You want to talk about that MD Anderson experience or retrospective analysis, and then in this patient who ends up having an IDH2 mutation?
Sure. So, I think, we think about FLT3 mutations, RAS mutations, those signaling mutations as something that happens as a patient goes from MDS to transforming to acute myeloid leukemia. And I think what hasn't necessarily been as appreciated is the IDH mutations, which about 15 to 20% of the time when you have a patient with an antecedent hematologic disorder, when they transform or they progress to an acute leukemia, they'll have an IDH1 or IDH2 mutation. So just kind of a reminder to everyone to make sure you're doing sequencing at that point. When your patient progresses, especially patients with underlying myeloproliferative neoplasms like primary myelofibrosis or essential thrombocythemia, when they progress to AML, over a quarter of the time they'll have an IDH mutation. So just important to be thinking about and to be making sure that you're getting sequencing at that point. And so as was alluded to, this woman who is 70, who's had a lot of azacitidine MDS for years, comes back at the time of her AML transformation to have an IDH2 R140 mutation. The PCR for FLT3 was negative, and so now we have more options. As Gail had been mentioning, we don't love the treatment options that we had for someone without a mutational target, but we now have a consideration for incorporating the IDH2 inhibitor. And so, one of the questions for, similar to the discussion on ivosidenib we had is, should we combine therapies with azacitidine? And so this was a study that was updated at ASCO that I just want to talk through briefly. Important to remember, this is different than our patient that we're talking about because these patients are getting azacitidine with or without enasidenib, so they could not have had a prior hypomethylating agent. So that patient would not have been eligible for this study. But what this study shows is that, the overall response rate and the complete remission rate when you're giving combination therapy, azacitidine and enasidenib together, are really substantially higher with the combination. We're seeing, overall response rates of, upwards of 70%. So similar to, that AZA-VEN data we were talking about. In terms of adverse events, the main side effect is differentiation syndrome, which happens in a small minority of patients. But when it does happen, in the combination 10% of the time, you need to be aware and you need to start steroids.
Now, I know you touched on it, but it's such an important topic. The last thing we need to really mention, Naval, I'm going to give it to you because I don't want you to fall asleep there, okay? And it's important. You really need to talk a little bit about IDH syndrome in terms of what do you look for and how do you treat it? Just the details,
sure.
Please.
Yeah, so differentiation syndrome is something that was seen with APL initially. Patients usually were atra-arsenic would present usually within the first 2 weeks with shortness of breath, fever, cough, hypoxia kind of symptoms. We're seeing this with IDH inhibitors. The published incidence is about 15 to 20%. And we've seen this clinically quite frequently. The interesting thing that is different in the differentiation syndrome of IDH compared to atra-arsenic is it can occur later during the course of the treatment, and it can occur multiple times. So we've seen some patients have multiple episodes of differentiation syndrome. Usually management-wise, we will give the patient steroids, dexamethasone 10 twice a day. It's quite a rapid improvement in symptoms, usually within the first 48 to 72 hours. We have continued IDH inhibitor in most cases, and that's what most of the guidelines suggest. Hydrea, there's controversy on whether to use it or not. For most patients, once their white count is going above 50, 60,000, we have tended to go ahead and add the Hydrea just to be more conservative and avoid getting significant leukocytosis, even if this may be monocyte and neutrophil. So I think it's very important to be aware. And also sometimes we get questions from the community saying, oh, we're worried the patient's progressing. I mean, there really is very low likelihood that on day 15 or 20 or 30 of an IDH inhibitor, a patient would suddenly become proliferative. It's possible, but I think the first thing you want to think about is differentiation, manage that. And then, of course, if you have persistent leukocytosis with blast, then you have to start thinking about acquisition of mutations and other issues.
Yeah, I want to give a bit of a twist to that is that I think this is one of the most challenging things. How do you distinguish differentiation syndrome with all those symptoms from disease progression and pneumonia or leukostasis? And I think you said it best, Naval. The rapid response to dexamethasone is one key. The differentiation you see on the peripheral blood smear with neutrophils is another. And then the other thing you alluded to, the co-mutational burden, mutations in the receptor tyrosine kinase pathway is often, not always, but often associated with lack of response. So these are all things you have to be looking for. And basically, what do we end up doing? We treat with hydroxyurea, we treat with antibiotics, and we treat with dexamethasone, and it'll declare itself after that. I have to move on. It's getting late in the hour or past the hour. And so, we don't have time to talk about all of the combinations that are now being evaluated. But what's really quite exciting for us is if you look at the current guidelines from the NCCN for the management of older patients with AML, there are multiple different options for these patients. And they're not all equal. And they're in terms of one size fits all and prioritize 1, 2, 3, 4. You really need to think about the patient, their goals in life, their co-mutational burden, transplant or non-transplant performance status. All of these things need to go into your consideration. And if you're still not clear on what to do, there are many of us around the country who would be more than happy then to get a phone call and help you walk through some of these points. But I'm going to have to stop at this point because it's been late. I really want to thank my co-faculty here, Naval Daver, Courtney DiNardo, Gail Robos. Thank you.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/JTP860. This activity is supported through educational grants from Bristol Myers Squibb and Jazz Pharmaceuticals Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.